Thank you, Dr. Rajesh, and thank you, Dr. Namrata and Dr. Sachdev, for giving this opportunity to me to be part of this wonderful symposium. Uh, am I audible?
Yes,
Yeah.
Paras, continue.
We all know that I would be in my talk, particularly, I would be focusing on the inflammation aspect of dry eye. We all know that after having gone through a lot of research and all, we have modified the definition of dry eye and we have focused more onto hyperosmolarity and inflammation and also on neurosensory abnormalities, which play an etiological roles into this. There are various triggers of dry eye disease, which we can see here. And this schematic diagram explains that very well, and which was already discussed by Dr. previous speaker very well. So we can move on to the next. If you look at the pathophysiology, the hyperosmolarity would damage the ocular surface directly, which would initiate a vicious circle of inflammation. Inflammatory mediators would damage the goblet cell. There will be loss of goblet cells, epithelial cell loss, which will in turn lead to further, deficiency onto the surface, leading to recruitment of inflammatory mediators. There would be activated T cells onto the surface, early tear breakup, tear film instability, and that would in turn lead to a vicious circle. So we need to break this somewhere. There would be some, incidences where like there are certain cases where there is no hyperosmolarity, but still they can have inflammatory element into the dry eye disease. Next, please. We can skip this because this circle was very well explained by the previous speaker. We can move on to the next. So the inflammation being the key element, one of the key element in dry eye disease, I would be particularly focusing on that area. Next, please. Next. Yeah. So the consequences of inflammation would be there would be tissue destruction, which would lead to neurosecretory block mediated by inflammatory cytokines. Next, please. Which can lead to reduced reflex tear secretion, loss of sensory drive to the lacrimal gland, the main lacrimal and accessory lacrimal glands, and decreased corneal sensitivity. The altered tear levels of the neuromodulators like calcitonin gene-related peptides, neuropeptides, or nerve growth factors correlate with clinical severity of the dry eye disease. Next, please. So the question here is, how do we diagnose inflammation? All these patients clinically would present with stinging, burning, redness, dryness, blurring, grittiness. They would have similar symptoms. And we see these patients in our clinic in and out. These symptoms are often exacerbated by conditions which would, increase the tear evaporation, like prolonged. They would explain that this happens on prolonged reading, watching television, working long hours on computers, and exposure to wind and air currents. Next, please. So initial patient examination is very important. Inflammation may not be initially evident or it can be overlooked in the mild dry eye patient. A lack of response or partial response to a current therapeutic approaches also may indicate that there is an underlying mechanism which is an inflammatory process. Next, please. So take a thorough medical history. Next, please. And determine other tests and move on to the diagnostic test. Next, please. All the we have all these diagnostic tests available. Like we know that which is to be done first. You can go for, if you have time permits, or if you have optometrist working for you, you can go for ocular surface disease index followed by examination of the face, slit lamp examination, tear breakup time. Next, please. We know that the cutoff value of tear breakup time, if it is less than 5, it is significant. Less than 10, it is significant. Next, please. One can go for surface staining with fluorescein as well as lysemin green, which would give a lot of important information. Next, please. Next. We can skip these details. And obviously, Schirmer test, though the value of doing Schirmers is questionable in recent times with a lot of other research going on. Next, please. But still, it gives you significant information. If one has an access to MMP9 testing kits, maybe you can use that, but this is optional. It is not mandatory to have this test. And you can identify the inflammatory element clinically also without undergoing, without subjecting the patient for this test. Next, please. So when we talk about the management, we know that dry eye disease being, multifactorial, the management is complicated. So the diagnosis precedes therapy. We have to essentially divide these cases between the two elements, in the sense that whether the patient has evaporative dry eye and an aqueous deficiency dry eye, which element is more. It is always a combination of both, but which element is more? And then also an assessment of major causative factors is also critical, like any other ocular surface disease. That will give you an idea about first, that is the first part. And then comes to the next part. Then you can divide these patients into a level, that is level 1, level 2, level 3, and level 4. Based on that, your management would be easier. Next, please. We have a very nice algorithm given by the DUCE group, where you can plan your management according to level 1, level 2, level 3, and level 4. Level 1 is a mild dry eye patient, where probably lifestyle management and topical tear substitutes would be enough to take care of those patients. Level 2 would be having an extra element of inflammation in there, that is little more than a milder, the higher side of the milder variety, or mild moving on to a moderate type of dry eye, where you would like to add anti-inflammatory agents. Without that, only the lubricants, drops, and gels will not be able to take care. And similarly, for level 3 and 4, you can add the other adjuvant, management options like artificial, autologous serums, contact lenses, permanent punctal occlusions, or other systemic anti-inflammatory agents, other surgical maneuvers. Everything can be put in. The best part of this is this nomogram is that when you diagnose the severity of the dry, it also helps you develop a treatment strategy based on the severity of the disease, and you can move the management part from second level to first if the patient is not responding to a primary management, and you can move some elements from third level to the second or to the first part. Next, please. So the question is, how do we address inflammation? Next, please. Variety of options are available. One is cyclosporine A, corticosteroids, oral tetracyclines, and macrolides, omega-3 fatty acids, dietary modifications, autologous serum, cytokine inhibitors, TNF alpha inhibitors, artificial tears. They also, to a certain extent, act as anti-inflammatory because they would wash away the cytokines based on the surface with the help of, tear substitutes and punctal occlusions. We will be focusing on corticosteroids and cyclosporine. Next, please. Corticosteroids are being used for a very short term to initiate the cyclosporine in the management part, because that would help in reducing the symptoms, and it would also help in reducing the inflammation, which can be given for a short term as 2 weeks to maximum 4 weeks. We have to be very careful, because these patients are having ocular surface disease, and if you use steroids for a longer period of time, they are more prone to develop infections, can develop cataract, or can develop corneal melts, or at times glaucoma. So, while cyclosporine A would take a longer period of time for its action to establish, it may take 4 to 6 weeks to establish its action. So it is good to supplement cyclosporine A along with, steroids initially. Maybe you could use it for 10 days to 2 weeks and simultaneously start cyclosporine A, which will help in better tolerance of cyclosporine A onto the ocular surface. Next, please. There are various studies which explains that there is change in the Schirmer score based on, use of cyclosporine for 6 months. Next, please. Which proves that there was a mean T-bar had improved over a period of 6 months, and there was improvement in the staining score of these dry eye patients with the help of cyclosporine over a period of 1 year. Next, please. Next. People have used it for long term, for 1 year to 2 years, where they had used, 2 different arms, where they started with, topical lubricants and cyclosporine A. And cyclosporine A definitely helped in improving the symptoms and Schirmer test score. And they replaced it with, lubricant at the end of 1 year. Then obviously that test score decreased, and when the lubricants were replaced with cyclosporine A, again there was an improvement in the Schirmer test score. So again, it establishes that cyclosporine A has significant anti-inflammatory role in dry eye disease management. Next, please. Next, please. So it can reduce the, usage of ancillary drugs. If you recall, and if you talk to your patients, many a times our patients tell that their requirement of topical lubricants has reduced over a period of 6 months if they are regularly using anti-inflammatories like cyclosporine from 6 times a day or every 2 hourly to many a times 4 times or twice a day. This itself tells us that definitely it has a role. Next, please. Next, please. Next, I think that was already talked about. Next, please. So we will move on to the clinical part. Here is a clinical picture of a patient presenting with history of often on red eye, irritation, gritty sensation, more so on waking up, and tiredness of the eye, not able to read for long hours. These are the classical symptoms with which the patient would present. If you look at the clinical picture, you can see that there are fine superficial vessels extending into the cornea in the superior part. And you can see some depressions onto the picture, which also tells that this is not a recent onset dry eye. This is a long-standing dry eye. Next, please. And when you put in a fluorescent stain, you can realize that there is no staining, but there is still a cooling of the dye. And that can tell you that probably there is a lot of insult to the surface. There is a chronic breakdown of the surface. And that means this patient is not falling into the category of mild dry eye. He or she is moving on from mild to moderate. And these are the cases who would require either a short course of topical steroids along with lubricants, and also taking care of their, meibomian gland dysfunction simultaneously. And if that is not enough, maybe you would like to add a cyclosporine to the management of this patient. Next, please. This is another example of a 45-year-old female who presented to us with pain, foreign body sensation, redness, blurring of vision, left eye more than the right eye, severe photophobia in both eyes, and intermittent worsening of the symptoms. Definitely, this is not falling into the mild category. This is moderate, and moderate going into worse. Because as you look at the clinical picture of the right eye, there are few filaments onto the surface. Both the eyes are demonstrating significant clinically evident bulbar congestion suggestive of presence of inflammation onto the ocular surface. You can see that there are lots of SPKs, there are depressions onto the corneal surface suggestive of chronic damage. There is a superficial subepithelial fibrosis, left eye more than the right eye, and lot of muck onto the surface, or mucoid filaments or discharge suggestive of chronicity of the disease and severity of the disease. So these are the cases who would require probably, these kind of anti-inflammatory therapy apart from lubricants in early on, before they worsen to this level of stage. Next, please. This is another example of 47-year-old female presented with redness, pain, photophobia, and discharge from one eye of a sudden onset. She did not give any history of trauma or a fall of a foreign body. Next, please. As you can see here, there is a lot of, the ocular surface is inflamed, there is a lot of muck onto the surface, lot of mucus filaments, there is foamy discharge at the lid margin, and obviously there is a small corneal superficial stromal scar suggestive of chronicity of the disease, and an area of paracentral corneal stromal thinning. Next, please. So would you like to ask for some more details in this case? Yes. She was already a known case of rheumatoid arthritis, was on topical management for dry eye disease, as well as also on systemic management for RA. So patients who are having systemic disease associated with dry eye, they can have exacerbations intermittently, even though they are already on management like this. Next, please. So it is important to keep in mind the possibility of systemic associations like primary Sjogren's, secondary to rheumatoid arthritis, lupus, GVH, or there could be a GPA or other systemic vasculitis. Next, please. So would you deal with these cases differently? Next, please. Yes, these cases would need special attention. They would not do well just with lubricants. If not attended early on, they can end up in serious sight-threatening complications, and even with their lifespan would be limited. So early recognition is a key for such severe cases. A careful history, other health-related issues, which they may think that may not be related, but you may have to, ask positively. Examination of both ocular and systemic condition also will reveal a lot of other information. If you suspect any systemic association, then investigate this patient thoroughly. A rheumatology consult is mandate, and sometimes a cross consult. Next, please. They may present early on like this. They may not have very severe presentation, just a lusterless cornea with surface staining. Next, please. If not attended early on, they may have diffuse SPKs all over the surface. Next, please. This could be a patient of primary Sjogren's or secondary Sjogren's. We may think in this patient there is a lot of foamy discharge at the lid margin. We may think that this is secondary to maybe probably a cataract surgery or secondary to anti-glaucoma surgery, but it may not be the case. So next, please. They present with like some filaments. This could be beginning of indication that these patients are having an inflammatory element, and we need to address that. Next, please. Some may have more filaments onto the surface and lot of surface staining and inflammation. Next, please. Again, here in this case, you can see a lot of inflammation onto the surface. The lid margins are bad. There are very fine, thin filaments on the surface, and patient is having severe photophobia. Next, please. These are different presentations. Next, please. This is a patient who is a known case of RA going or maybe a Sjogren's syndrome, having moderate to severe dry eye. The surface inflammation is quite significant, and this really needs to be under control. Do not allow these patients to move on to this level. This has both the elements, evaporative dry eye as well as severe aqueous deficiency dry eye. You move on to the next slide, please. This was a case of, on investigation, it turned out to be a primary Sjogren's syndrome case with a moderate to severe dry eye. He or she was treated on topical lubricants, management of meibomian gland dysfunction, given a topical short course of steroids for 2 weeks, along with topical cyclosporine A for long term, and systemic management as well with a rheumatology consult. And you can see that there is a significant improvement into the corneal surfaces compared to the previous slide at 4 to 6 months of continuation of the treatment. Can we go back to the previous slide first and then again go back to this slide? So you can see the difference between the two. Next, please. Yeah, you can see the difference on the ocular surface. Unless you treat these patients on long-term anti-inflammatory therapy, they will not do well, and they will end up with maybe corneal melt or significant corneal scarring and so on and so forth. Next, please. This is also a chronic condition. The picture on your, left-hand side shows, this is the case, this was referred in this stage, and this was the picture on the right side shows after management with short course of topical steroid, cyclosporine A, and obviously lubricants, and you can see that the eye has gone much quieter, and even the surface is looking much better. Even clinically, you can assess that this patient has better probably, Schirmer score and T-but time, and the staining also must have reduced. You can see the luster of the surface itself clinically. So it's not necessary that, every time you have to rely on certain lab diagnostic tests. You can look at these things clinically as well. Next, please. These are the cases who would require immediate referral, like sometimes the patients would present with corneal melt like this. There are telltale signs into the other eye of the patient. You can see a paracentral scarring and some scarring into the inferior part, also suggested that the process is going on since long. Next, please. This could be the varied presentations. Patient can present with corneal melts. Next, please, or a PUK. So these, the immune corneal melt can classically present. It could be unilateral or bilateral. It could be present paracentrally. The eyes would have other signs of dry eye. Usually these immune-mediated melts are sterile and without any history of trauma. The corneal melt is rare, and serious complications are seen in patients with rheumatoid arthritis. It heralds systemic vasculitis in more than 50% of these cases. It carries a high mortality rate, so you have to recognize this patient early on. And these are the patients who require immediate referral to a cornea specialist and maybe to a rheumatologist. A sterile melt in dry eye with RA patient should raise red flags for a clinician for immediate management. So what should be our role as an ophthalmologist? Restore the ocular surface homeostasis, control ocular surface inflammation, that is a key. Treatment based on the severity of the disease process. So decide what is the severity level based on your diagnostic tests and clinical history. Focus the management based on the possible etiology. Treat the systemic condition if it is present, and co-management with rheumatic consult or immunologist. And patient counseling in such cases is a key to make them aware about the chronicity of the disease and make sure that they continue using anti-inflammatory drugs for a longer period of time to avoid sight-threatening complications and to reach to a minimum maintenance therapy. Next, please. I think I may not go into the ophthalmic details of the ophthalmic management. Next, please. So the clinical pearls here would be history, good clinical examination, followed by diagnostic tests, which would help in staging the disease process. Next, please. So mild dry eye can be tackled with lifestyle modifications and topical lubricants, etc. But if it is moving on from mild to moderate, maybe you have to look at the element of inflammation, and then you add adjuvant therapy in terms of, maybe probably topical steroids and cyclosporine to control the ocular inflammation. Topical cyclosporine will be a better adjuvant for a long-term use in indicated cases. Always look for systemic association in moderate to severe cases, and those cases would need definitely a referral for further investigations, or make yourself, or update yourself to be able to treat these cases, and then also it should be fine. You should be well oriented to treating these patients. Next, please. So thank you for your kind attention.